Bueno, ya siendo las 7, buenos días. Hoy traemos un invitado muy especial, el doctor Andrew Petrosoniak. Él es especialista en medicina de urgencias y líder del equipo de trauma del Hospital San Michael en Toronto, Canadá, y profesor también de la Universidad de Toronto. Si tienen alguna pregunta, la pueden ir dejando en el chat, o decirlo en español al final de la charla, y yo al final pues la puedo intentar traducir, o si la quieren hacer en inglés. También eso, pues, es otra posibilidad. So, good morning, everyone. My name is Juan David Arevalo. I'm an emergency medicine resident at the University of Antioquia. Today, I want to introduce a very special guest, Dr. Andrew Petrosoniak. He is an emergency physician and trauma leader at St. Michael's Hospital and assistant professor in the Department of Medicine at the University of Toronto. He is also a speaker both nationally and internationally on topics of trauma, simulation, decision-making in the emergency department, and procedural skill acquisition. And today he will be speaking on a very interesting and important topic, that is decision-making in the emergency department. Thank you, Dr. Andrew, for accepting the invitations. So go ahead, you can start now.
Okay, well, thank you. I put my video on just in case people wanted to see me. Buenos dias. My Spanish isn't very good, so no puedo dar esta charla, esta presentación en español. Maybe next year, but not this year. So thank you very much, Juan, for the invitation. And I'm going to share the slides. This is a topic that I really enjoy, and so hopefully each of you have maybe some thoughts and questions. And Juan, can you see the slides okay?
Yeah, I see the slides.
Great. So this is a talk Juan and I were discussing, what this should be about. And I think all of us, we learn about trauma, we learn about cardiac arrest, and we learn about different topics, but one that we don't learn that much about explicitly, or that we're taught, how to think about it at a high level is decision making, and it's one that I really like, and it's an honor and a pleasure to be invited here to speak with you guys, and let's get into it. So we're going to talk about some decision-making principles, what I call the elite 8 of decision-making tactics, and then sort of how does this apply directly to emergency medicine. And each of the everything that I'm going to kind of speak about today I'll tie in directly to emergency medicine. I'm an emergency medicine physician, as Juan mentioned, in Toronto, and I spend time also doing trauma on a regular basis. We have a separate, I don't know what it's like in Colombia. We have in emergency medicine, in many places, the emergency physician takes care of the trauma patients until the surgeons come. At St. Mike's, where I work, the trauma, I have specialized training in trauma resuscitation. So actually our trauma surgeons really don't do a lot of the initial resuscitation. Instead, they wait until there's a decision to take the patient to the operating room, or make a decision with them. But our trauma surgeons actually do less of the resuscitation part, and that's actually more done by specialized emergency physicians called trauma team leaders. And so that's how it works. And because of this, I spend a lot of time working with a specific team, and this is where my interest in this type of stuff comes from. So like I was mentioning, I bet you, or I don't know what school is like in Colombia, but in Canada, we don't learn how to make better decisions. We learn about specifics. You learn how to make a decision about a patient with chest pain. You learn how to make a decision about a patient with, serious trauma. But at a high level, it's very rare that we're taught, whether it's in primary school, secondary school, university, medical school, residency, how to make better decisions. And yet this is the most important thing that we do every day in emergency medicine. The decision density, the number of decisions that we make in a shift is among the highest of many, most professions. We have so many decisions that we're asked to make. And so it is a bit crazy that we don't learn how to make them better. I don't know if this idea has come to Columbia, but there's a book, Thinking Fast and Thinking Slow, that was published a few years ago by a famous researcher, Danny Kahneman. And he talks about System 1 and System 2 as the two kind of general ways in which we think. System 1 is that very quick way of thinking. We call it intuition. We just know we need to do something. When you see a patient in cardiac arrest, you just know that you need to start CPR or that you check a pulse. System 2 is that slower, more rational thought. And that's this idea of, maybe you see an ECG and you're trying to decide if this patient has, some type of ACS, some type of a STEMI, a heart attack, whatever, or some arrhythmia, or is there something else happening? And it's a very much more slow pace. These are nice ideas, though at the bedside or in the emergency department, we're not thinking we're not going to ever reflect, I'm thinking in System 1 or System 2. This is more, I think, better, if you're doing research. The other thing that we've come to realize is this idea about bias, and the idea that bias around thinking, cognitive biases, these ideas that in emergency medicine we try and prevent or reduce. Well, it's almost impossible. And for a little while, we started trying to study if we teach people about all of the biases, and there's many, things like anchoring bias or recall bias. For example, let's say you just had a patient with an aortic dissection last week, and then the following week you're in the emergency department and you see a patient with chest pain and you think, well, this seems similar to the patient with a dissection last week. I'm going to do a CAT scan to look and make sure they don't have a dissection. That would be sort of a recall bias or a recency bias, meaning because you saw something recently, it's more likely to be possible. And what we've come to realize is that you can't teach people all the biases as a way of preventing them from happening. It's just not possible. It doesn't work, because the whole point about a bias is that it's built into how we think. So we can't really get rid of them. And in fact, sometimes they're quite helpful. Oftentimes they're actually quite helpful. It's only when they're not helpful that we try and get rid of them. Because you think about a patient that comes into the emergency department in cardiac arrest, you immediately know what to do. You don't spend any time, you immediately start CPR, and then you start to go through trying to figure out why they have cardiac arrest. And if we got rid of biases, then that thought process would be much slower. The other thing that's really important, and I'll tell you a story here. This is little Johnny. I don't know little Johnny, but I guess in Spanish you would call him little Juan. He's walking across the street and he comes home and he tells his parents every day he walks to school, but he never looks both ways. And his parents are shocked. And they say, Johnny, that's so unsafe. And he says, yeah, but I've never been hit by a car. And his parents are like, yeah, but that's not a good idea. You should never walk across the street and not look both ways. And what we're describing here, and what little Johnny is telling us or showing us, is this idea of process versus outcome. His process to get to school, to walk across the street and not look both ways, is terrible. But he's just been fortunate enough that there's been no bad outcome. And it's very difficult for us, and this happens in emergency medicine. We worry so much about the outcome, which is important, but often the process is equally as important, and we forget about that. And so when we're thinking about decisions, we can't ignore the process by which we come to them. And if we can start to focus on the process, for example, if we can teach little Johnny that he should look both ways every time he crosses the road, we can guarantee a better outcome. Versus if we don't, if he never looks both ways and keeps crossing the street, there's a chance that he's going to get hit by a car, or that chance goes up. And the same with emergency medicine. If you see a patient in the emergency department who has chest pain, and you say, there's nothing wrong with you, but you do no testing. You don't even do an ECG. You just see the patient, you hear the story, you say, you can go home. You're fine. You do an exam, you listen to their history, you say, there's nothing wrong. That's a pretty terrible process, but probably the outcome will be fine, because it's not that common that every patient with chest pain has a problem. Many patients, at least in Toronto and Canada, I don't know what it's like in Colombia, but many patients come to the emergency department and with chest pain, and most don't have, a specific diagnosis. We do all the right tests. But in this case, if we did all those tests, or if we didn't do all those tests and we just sent the patient home, that's a very awful process. But we often measure our successes based on our outcomes, which is the problem. And rather, more importantly, and you'll see this throughout my talk, the process by which we get to that decision over time, if we make it better, will result in better decisions. This is the 70% rule, or the 70% idea, is something that I think many of you are used to in emergency medicine. It's this idea that we make most of our decisions without 100% certainty. And we struggle. It's difficult. I struggle when I'm trying to decide about whether I should do something, whether I should intubate a patient, without all of the information. I don't know what will happen if I don't intubate the patient. I have no idea, because I can't see to the future. So I'm left making a decision with only some of the information. Obviously, if a patient comes in and they're having respiratory distress and their oxygen saturations are low, we usually put them on oxygen, and we then reevaluate and see what happens. But at some point, if they're not getting better, I have to make a decision whether we should intubate them. And we have to start getting comfortable with making decisions with some degree of uncertainty. If we wait till we have 100% certainty, then it will be too late. And so I try and think about somewhere between 50 and 70%. Do I have the information I need to make a pretty good decision? And then as we finish up on some of the things that impact our decisions, I think this is really important, especially in emergency medicine, which is, I would imagine, some degree of shifts. I suspect many of you work overnight. we do in Toronto because patients come to the emergency department at all hours. And the time of day matters for our decisions. Over the day, we do experience a burden of decisions, many decisions over the day, and it becomes harder, I think, at the end of the day, and this would be supported by some research, that our decision-making quality gets worse. It's much better in the morning, and probably through the day, it sort of degrades. And so we can't ignore, if you're in the middle of it's 2 a.m, then it can be difficult to kind of make that decision, the same decision you might feel great about making at 7 a.m. And then finally, when we start to think about our decisions, we can't ignore this idea of luck. Sometimes it's just bad luck, something out of our control. Not all of the things that we do are within our control. Patients that come into the emergency department in cardiac arrest, we can have done an amazing job trying to resuscitate them, but if they were without CPR for too long before they come to us, sometimes there's nothing we can do. There's no chance that we can revive them. And so that the outcome really isn't about what we've done. It simply was bad luck. But it's many people find that hard in medicine to talk about. And so I want to shift gears, or I want to sort of move into what we can do in the emergency department to help us make better decisions. And these are what I've called the Elite 8 decision-making tactics. And at the end, I'll show you a little bit how I apply this in a specific case, but I'll give you examples throughout. And it's not that you'll use each one of these all the time, but these are like tools that you can use at different times in your shift. Many of you might be using these already. I use these, my colleagues use these, but this is a conversation around how we can get better at our decisions and understand a little bit about where do we fall short and where we can improve. The first thing we can do with improving our decision making is to actually reduce decisions altogether. The idea of using a default, meaning if there's something occurring, then we do a particular action. For example, for patients with chest pain that come into the emergency department, for me, I've decided that I'm going to do a troponin test for all patients. Now, that doesn't mean that I may, in certain instances, not. If you got punched in the chest and you have chest pain, I won't. But my default is that I will do a troponin if you have a non-traumatic chest pain. Because there are times where I've observed where even when I don't think the patient has a cardiac problem, I'm surprised. And so if I can reduce these decisions, this is much more helpful. If you think about it, I don't know how many of you ever try and eat healthy or eat healthier or eat better. In the morning when you wake up, you might think to yourself, yeah, I'm going to eat much more healthy today. I need to be more healthy. Let's start the day great, have a great bowl of fruit and a coffee, and I'm not going to eat, lots of terrible food. And then by the end of your shift, you work all day. By the end of your shift, you'll eat anything you possibly can, any junk food you possibly can. Because throughout the day, as you make more and more decisions, it gets harder to be so good at them. And you fall victim to certain things. Just like when we're trying to be healthy, but throughout the day, as we make more and more decisions, we just get tired and we say, whatever, I'm done making that decision. I'm just going to eat junk food and go to McDonald's or wherever. So this idea, if we can reduce decisions, and there are rules now that have been developed, many of them actually are Canadian, from some colleagues of mine in Ottawa, the Canadian, you might be familiar with them, Canadian CT head rules, the Canadian C-spine rules, the Ottawa ankle rules. These are ways of helping you reduce decisions so that you don't have to think so much about it. You can kind of follow an algorithm. Now, that's not always great, but it is one tool that you can use. The next thing is the sunk cost fallacy. And it's important to understand what this is, because then we use a particular tactic. And this is this idea. Imagine you buy tickets to a concert. You spend, well, I'll use Canadian dollars, 100 Canadian dollars for a concert. And you buy the tickets, and then on the day of, and this is what happens in Canada. In Colombia, it'll be slightly different. But in Canada, there might be a snowstorm, okay? And for Colombia, I don't think you guys have snow like we do. So maybe a rainstorm, a thunderstorm. But a snowstorm happens, and suddenly it's a bad idea to drive on the roads. But you've already bought the tickets for the concert. And so people feel, I buy the tickets, I'm supposed to go with my wife to a concert. I've spent $200, $100 each. And now it's a snowstorm or a rainstorm if I'm in Colombia. And I make another bad decision by saying, you know what, I've spent the money, I got to drive on the roads, even though I'm now putting myself at risk. Because the sunk cost is already there, meaning I've already purchased, paid the money. Whether I go to the concert or not doesn't matter. I've already paid the money. And it's a hard thing for us to get our heads around. The fallacy or the problem is that now I'm making a bad decision about driving and being unsafe and maybe crashing my car and ending up in the hospital. I'm making that decision because I feel like I have to make it worth it. I have to do it because I've already paid the money. But in fact, that's a bad idea. You should make the decision regardless, because you've already paid the money. It doesn't matter. The money is gone. It's sunk. And so this happens in emergency medicine all the time. The idea that, think of maybe the last time, I'll tell you, when I was intubating a patient a few months ago. And as I was intubating the patient, the oxygen saturations were dropping. And I got to, the oxygen saturations came down to about 85%. And the team is like, okay, the sats are 85%. And I'm like, oh, I'm almost there. You have the tube in the mouth and you almost have passed the tube, but it's a little bit tricky. And you keep saying, I just need a little bit more time. And yet, by giving more and more time, or by taking more and more time, you're putting the patient at risk because the oxygen saturation keeps dropping. And that's the sunk cost fallacy. Because I feel like I've spent all this time getting ready for the intubation and I'm almost there and I've almost intubated, that I feel like I shouldn't stop. So I'm making a bad decision. So the way in which we try and combat this is to signpost decisions, meaning say ahead of time, I'm going to intubate this patient. If at the patient's oxygen saturations go below 90%, I tell my team, I say, I need you to stop me, tell me that the sats are 90%, and I will stop. We'll try and bag the patient back up. to, 95, 100%, and then I'll try again. And the importance is you do it before the problem occurs. So you create a sign ahead of time so that you aren't emotionally invested in the decision. You say, yeah, you're right. I said that ahead of time. I'm going to come out. If the SATs go to 90%, you just tell me and then I'll do it, because I can be held accountable for that decision. And this is one that I use very often. The other time I use this is when we put in an arterial line. And I don't know about you, but sometimes I struggle with a radial arterial line. Sometimes they can be tricky. And I like them, though, for our trauma patients sometimes, especially if they have a bad head injury. But sometimes I need to go to CAT scan with them. And so I'll be putting in the arterial line and it'll take me longer than I expect. And I keep trying, but what I'm doing is I'm delaying the patient from getting to CT scan when they need a CT scan of their brain. And so what I'll do is I'll say, I'm going to take 3 minutes to do the arterial line. If I can't get it in 3 minutes, I'm just going to stop. And so that way I don't commit the sunk cost fallacy. I signpost the decision, and I can prevent that from occurring, falling victim to the sunk costs. The next thing that we can do to improve our decision making is considering more options. We do this very well in emergency medicine. We're good at thinking about the differential diagnosis, the possibilities that the patient has. But sometimes, or we should get in the habit of deliberately forcing ourselves to think about a few extra options, push ourselves, because we will often come up, if a patient comes in with fever, we'll come up with a few ideas. What do we think's happening? Our differential diagnosis. But it may actually be that the patient has a non-infectious cause of fever. Maybe they have some type of rheumatologic process, or maybe they have a toxicologic process that's happening. And by considering more options, by forcing yourself, after you've said that your differential, could there be anything else? Then we can start we will sometimes consider some things and we'll be able to act on them, and it will help make a better decision and come up with a better idea of what's happening. So for me, I'll see a patient, do my history, physical, come up with my ideas, come up with a plan. And then when I'm writing it out, when I'm writing my impression, I always ask myself, what else could this be? I've already thought about what it could be, but I will force myself to say, is there anything else I'm missing? And often I'll come up with ideas like an endocrinology problem, or is there a vascular problem, or whatever, some other problem. And it allows my differential diagnoses to expand. And that's one of the biggest pitfalls in decision making, is that we fail to consider all the options. This one is my favorite. This is the idea of assigning probabilities to something. And I think it's most useful or very useful when we're talking about what are differential diagnoses. What's the probability that this patient has a specific diagnosis? And so if we take a patient that comes in and they come in with chest pain, and we do a history and a physical, and we come up with a differential diagnosis, and we say it could be ACS, acute coronary syndrome, it could be a pneumothorax, could be pericarditis or myocarditis, It could be a PE. We could say, yeah, I thought about it could be an aortic dissection, but it doesn't seem to be. But what's a better way of doing that is assigning probabilities to the best of our knowledge, specifically for the diagnoses that are rare. So if I say, you know what, I think it's likely, or maybe I think it's unlikely to be an aortic dissection. A patient comes in, they have chest pain, it's not tearing, it doesn't move to the back, but they have maybe some numbness and tingling in their left arm. And so we think about, could this be an aortic dissection? And the idea is that rather than saying unlikely, I think it's unlikely to be aortic dissection. In our minds, humans, when we hear unlikely, we think that it's not. It's a 0% chance. We're not very good at thinking in probabilities without putting a number on it. So what I'll say is, I think it's less than a 1% chance that it's an aortic dissection, or I think it's 5%. Now, if it's a 5% chance, am I okay with not doing any further investigations? And that depends on the diagnosis. But by using specific probabilities, by saying, I think it's a 50% chance or a 10% chance this patient has an aortic dissection or a pulmonary embolism, I can then make a better decision as to whether I should go forward with investigations. Instead of simply saying, I think it's unlikely, or I think it's likely. And so using specific probabilities for your decisions will help you throughout all of the decisions that you're making. The other thing that we can do is we can simplify the situation. I don't know about what the situation is for patients in Colombia. In Canada, I suspect it's the same. But in Canada, our patients are getting more and more complex. And sometimes they don't tell us exactly what's going on. And imagine an elderly patient, an older patient, they're 85 years old and they aren't feeling very well, so they come to the emergency department and they have a fall and they start telling you all types of stuff. They tell you about where they live and what they ate yesterday, and that they had a bit of chest pain and that they're dizzy, and then they tell you about where they live and all of this stuff. And sometimes it becomes difficult to know what to do. And so we talk about this, about trying to simplify the situation or create a one-line summary. Imagine the one-liner that you would see on an exam about this patient. If you write an exam, what would be the one-liner that you would write or that you would see on the exam? If I said, well, this is an 85-year-old patient presenting with chest pain, suddenly it becomes much more clear what you should do, rather than this patient, when they tell you all of these extra things, it becomes too much. So sometimes simplifying it, creating a one-line summary in your mind, can help you when it feels a bit overwhelming, or that when you're getting focused on the wrong things. Next is learning from decisions. And this is this idea that we can actually improve our decision-making over time. We're not born to be excellent at decisions. We get better over time. This is a skill, just like you are not born to learn how to drive or to know how to drive. You have to learn. Why we think we should just be good from birth at decision making doesn't make any sense. And so we should imagine that we can learn from our decisions about how we made them, and we can reflect on them and see if we can do better the next time. And that's the key to learning. And this is this idea of a decision-making reflection. And I don't do this all of the time for every decision, but this is a way in which you can explicitly come up with, what was my decision? When did I make it? How was I feeling? What were the other things that I didn't pick? What were the possible outcomes? What did I think was likely? What actually happened? And then thinking through, what did I learn? And you don't have to write this down, but this is a decision-making journal. And it is shown to be helpful that if you can reflect on your decisions, you can get better over time, because you will change what you're doing. If every time you see a patient with chest pain and you think that they're having an aortic dissection, and you say, yeah, I think this is 90% chance of aortic dissection, and none of them ever have an aortic dissection, then you need to reflect on that. Why do you think that? And clearly you're wrong. So how can you change? What new information do you need to look up? How do you need to learn to make a better decision? And finally, you can debrief your decisions. And I don't know if you do this in your center, but we come together and we talk about why we made a decision the way we did, so we can hear from other people. So when we run a cardiac arrest, we'll come together afterwards and we'll debrief. We'll come together and we'll talk about, I made a decision to intubate the patient. I made a decision to, maybe we have a patient that came in with cardiac arrest, and ultimately you find out that they had hyperkalemia. They're a dialysis patient and their potassium was 9. And you debrief about, did you make the decision, why did you make the decisions you did? What information did I have at the time in the moment? And what could I do better next time? And worry less about the outcome, but more about the process. And so I'll give you an example of how I use this practically. This is our trauma bay at St. Mike's. What's going? Why did that happen? Okay, 1 second. There's a piece of the slide not missing. 1 second. Why is that not there? Sorry, I don't know what's going on. Okay. All right. So let's say we have a 69-year-old who comes in with what we think is sepsis. Rule out sepsis. Sorry, there's some things here that wouldn't make sense in
Dr. Andrew, are you sharing a screen?
Oh, did it not share? Okay, hold on.
No, you're not sure.
Thank you. 1 second. Okay, let's do this again. Good?
Yeah, good.
1 sec. Why is that not? Okay. Slideshow. Good. Okay. You can see one?
Yes, I can see.
Great. So a 69-year-old coming in with fever, cough, we think they have sepsis. and we think they have pneumonia. She had a fall. She hit her head. She lost consciousness because she was dizzy. She vomited in the emergency department. Her GCS is 12. Her temperature is 39. Her blood pressure is 110/70. Her heart rate's 120. She's on oxygen. And so, how do I use these tactics that I talked about? Well, the first thing is I look at this patient. So we'll go through a few of these. Number one, I'm going to try and reduce decisions. I don't know why this patient has sepsis. I think it might be pneumonia, but they seem pretty sick. You know, she's got a high fever. Her level of consciousness is altered. She's requiring oxygen. So for me, when I see a patient this sick, I'm going to just choose. In Canada, we would give this patient Pip/Tazo or piperacillin tazobactam. I've just decided that I'm going to give, when I see patients that are sick with sepsis, I'm going to give them a broad spectrum antibiotic. It doesn't matter which one you pick, but I've just decided that before I even see this patient. This is just my rule. I've created a rule because I don't want to think about which antibiotic. It doesn't matter. Just make sure that she gets broad spectrum antibiotics. I don't want to waste time looking up which ones I don't know what is her problem. I think that she has pneumonia because of her cough, but maybe I'm wrong. And then, so I'm going to reduce decisions and I'm just going to give Pip/Tazo. The next thing is I'm going to assign probabilities. I'm going to say, what's the probability? I think this patient, she needs a CT scan of her head. Okay, she needs a lot of things. She needs to be admitted to hospital. She needs IV fluids. She needs resuscitation. But what's the probability that I think she might need intubation? Okay, I don't know for sure. Maybe we could wait and see, but I need to get her to CAT scan to see if that head injury has caused any bleeding after she had a fall. And she's vomited in the emergency department. So maybe she's vomiting because of sepsis, or maybe she's vomiting because of a head injury. I don't know. And so I'm going to look at her and I'm going to say, what's the probability that if I bring her to CAT scan right now without intubating her, that she's going to vomit, that I'm going to have to intubate her in the CT scanner? And I think that probability is, I'm going to say 30%. And so as soon as I say that, it suddenly becomes more clear to me that I think I should intubate her before I go to CT. Each of you will have your own probability. Some of you might say 5%. If it's 5%, then it seems pretty reasonable that you bring her to CAT scan without intubating her. Some of you will say 80%. Well, if it's 80%, that means 8 in 10 times she's going to vomit in the CT scanner. You're going to have to suction her. She might aspirate. Then that would be a bad idea, and you should intubate her before. But assigning an actual probability will make your decisions better. We decide to intubate her. And I say to my team, once I hit, we're going to go ahead and intubate her. And I say to my team, we're going to signpost a decision. If the oxygen saturations drop below 90%, I want you to tell me. And whatever I'm doing, I'm going to stop intubation if I haven't been successful yet, and we'll administer BVM and bag her back up and get her oxygen back up. And so I've signposted that. I'm not going to wait. I'm not going to fall victim to the sunk cost fallacy. I'm going to signpost the decision. And then I'm going to consider options. So I've intubated her, and now I'm thinking about what's wrong with her. Well, it seems like she has a fever. She has an altered level of consciousness. Maybe she probably has sepsis. But as I'm thinking through this, I'm going to say, is there anything else this could be? Is there any reason maybe she has, what else could this be? And I'm going to force myself to consider other options. I'm going to say out loud to myself, what else could this be? Could this be, could she have a PE, a pulmonary embolism? Maybe. But, you know, I think with the fever and everything else, I think it doesn't seem likely. And my chest x-ray shows signs of pneumonia. But I force myself, could this be that she has an altered level of consciousness because of the fall? Could she have a C-spine fracture? So I consider other options. I push myself to consider these options explicitly. And we continue our resuscitation, and then we bring the patient, we intubate the patient, we eventually bring her to the ICU. And then afterwards, I follow the patient, you know, I kind of see what happens, and I debrief with my team, and we learn, and we debrief, and we think about where we could have made improvements. We think about our process. Did we have all of the information available to us? Was there something missing? Would that have changed what we have done? If we could have gotten that information, would we have done something differently? Or maybe we would have done the same thing. And so we actively reflect, because the next time this happens, I will be better. And so there it is. Those are the 8 tactics of decision making. We reduce decisions when we can. We signpost decisions, call them out ahead of time. We assign probabilities. We expand our options. We simplify. We learn and reflect. We debrief. And I didn't mention this one, but we run the pre-mortem. And we do this pretty often. And this is the idea, for instance, when we're intubating a patient, we're pretty good at this in emergency medicine. We say, let's go through, imagine a situation where we couldn't pass the tube through the mouth, through the trachea. What is our plan? And the pre-mortem is the idea of, imagine something going wrong. Why did it go wrong, and what are we going to do about it? And you don't imagine if it happens, but you put your team in the position and say, when we can't intubate, not if, but when. When we can't intubate, what is our plan? And the plan will be, you know, maybe do a crike, a front of the neck access airway. Maybe we'll bag the patient back up, whatever it might be. But it's important to frame it as, when something happens that's you know, not ideal, what will we do? And that's what we call a pre-mortem. So that's it. No decision is in itself a decision. I'll stop there, and I'm happy to answer questions.
Okay, thank you, Dr. Andrew, again for accepting the invitation and for the excellent talk. At the time that you accept the invitation, I really didn't know what topic to propose. After discussing it with my colleagues, I decided that decision-making in the emergency department will be a great topic, specifically because if you think about all the decisions that we make in a given shift, like you mentioned, you can see that some of the decisions are very huge. Decisions like when to end a resuscitation, when to intubate a patient, and others that only occur that we don't really think about it, like some examples like interpretations of lab results or interpersonal decisions we make every day, like an argument with a nurse or a consultant, or a simple personal decisions like when can I use the bathroom or when can I eat in a shift. So in the emergency room, we become like the masters of balancing multiple tasking. Our brain process like different stimuli at the same time, and at this moment you ask yourself, how did I learn to do this? Like, at what moment, how did we evolve from a simple intern struggling to handle the details of managing only one patient to attending to become an attending physician capable of smoothly running an entire department while being bombarded from every site. So, however, with the tips that you just gave, like the 8 Elite, I believe that if we apply them to our daily practice, we could reduce this cognitive load that we face every day and make better decisions for our patients. Thank you very much, Dr. Andrew.
Oh, you're welcome. Thank you. And you did a nice job summarizing, Juan. Thank you. If anybody has any questions or comments, I would
Yeah,
be
yeah.
happy to hear.
La doctora Luz Adriana tiene la mano levantada.
Hi, good morning. I want to ask you, when you told about, we previously tell our team that we're going to stop when the saturation is under some point, no? What happened if during the procedure I consider to change my mind? I think maybe it's too fragile, it's bleeding since I put the tube, I trying to put the tube, start bleeding. What happened if I want to change my mind? The team will tell me, okay, you said you stop. How to make the difference between I change my mind, I'm taking a good decision now, or I just not obeying, for something to say, obeying the order I previously did?
Right. That's an excellent question. I think, so I love that question, actually. And I don't know that there's a right answer. Here's what I would say is, as long as you can then in the moment, with your team, you say, I actually need to keep going with this. And let's use intubation as an example. And you give a good example. Maybe there's now bleeding in the airway. You at least are now actively reflecting and something has changed. You've said, if I don't continue, I don't think that if I come back in 5 minutes or in 2 minutes after I give oxygen to bag the patient back up, that the airway that I'll be able to secure the airway. We have to now go because now the situation has changed. But at least your team can hold you accountable, and then you can outline and say, listen, I have to continue, or you're right. You know what? I think that it is, you're right. I did say 90%. And let's stop and we'll come back. And so it's not that you can't, if you signpost your decision, if you declare something ahead of time, it's not that you have to stick to it all the time because things will change. It's just that you should be actively thinking about why you should do that. Just like when you decide to buy concert tickets, the example I gave, you buy the concert tickets. You spend a lot of money. You want to go with your friend or your family member or your partner, and then the weather changes. That doesn't mean you still shouldn't drive. Maybe it's not that bad. Maybe in Canada, maybe there's not that much snow. Maybe for you, it's maybe rain, I guess. But it just means that you should pause and not think about what the time you've just spent or the money you've just spent. You should think about the decision in front of you. I have an airway that is bleeding now because I've started to intubate and I've caused some bleeding. Should I continue or not? Now I have to do that independent of what's happened in the past. And that's all that needs to happen. So it's a great question. And all it should do is make you very active in that decision in the moment.
But is there any number of signposting? Like how many signposting can I tell my team before I do something? It seems like I've never seen someone do that. So I don't know. In which moment I do it? If maybe the patient goes and needs CPR. And so I should put signposting when we start CPR? Please stop me when 15 minutes have passed. So I don't know.
Yeah, I do it often. So for instance, I was just running, great question. Obviously you can't have too many because I don't know what the right number is. But for instance, last week we were running a cardiac arrest. I was in charge. I was the team leader. And I said to our nurse, I said, I want you to just give epinephrine every 5 minutes. And don't worry, just keep doing it. And I'll come, and after you've given 3, come and talk to me. Because we were trying to do some other stuff. We were trying to figure out why this patient had cardiac arrest. I was talking with another doctor. I didn't want to think about the epinephrine. So we signposted. I figured it was going to be safe to give, unless the patient gets a pulse back. But if we didn't, I said, just do these things and then come back to me. And here's what we're going to do and go through it. And so I think that I use signposting for big decisions or big things like intubation or, what's another one? For instance, when I'm doing a procedure and the patient also needs to go to maybe the operating room or go to CT scan, and I will say, I don't want my procedure to delay the patient going to where they need to go. And maybe the procedure is important, but maybe it's not so important. Like maybe you want to put an arterial line for a patient to monitor their because they have a head injury. It's probably helpful to have, but you don't have to have it. I don't want to delay the patient going to CAT scan. So I will say, I'm going to signpost in 3 minutes. I'll tell my nurse, can you tell me when 3 minutes happens and tell me to stop doing the arterial line if I don't have it, because we got to go to CT. So I do, 1 or 2 maybe per patient, kind of big things. But there's no right answer. But I've never had that question before, and I've given this talk before, and I like it. I think it's a great question.
Well, I'm trying to imagine or put myself in the situation. So what happens if I get rid of the decision? Please let me know when something, no, I don't know, decide, whatever. And the team does not tell me. And I've already forgotten. I'm not paying attention to that because I've already put the signposting. So I think someone is covering me. And the team doesn't, well, something happens, we are really busy, and we don't do it. The team doesn't tell me stop or whatever the sign. What happens?
That's a great question too. Too many good questions. I don't know. I don't have an answer to that. I think what you want to communicate is how important it is that signpost get communicated back to you. So, if we use intubation, listen, it is most important. Most of the time when you're intubating a patient, the entire team is focused on that intubation. It's rare. I guess there's sometimes other things happening, but in our department, if we have 4 or 5 team members in with that patient, the nurse, doctor, 2 doctors, sometimes we have a respiratory therapist, a few different people. I kind of say out loud, I say, the most important thing that we're doing right now is intubating this patient. I want everybody to focus on this if I'm the team lead. And I will say, I need someone to hold me accountable for the oxygen. Like that is your job. And so that just has to be very clear that that's their primary job. If we hit 90%, so that it's your job to communicate the importance of that. Obviously, people behave.
I tell that to a single person or just all the team? Or
I tell the whole team. I tell the whole team, but I will say out loud, listen, okay. At 90%, if you guys see me, if it hits below 90%, you tell me to stop. But I will then say to one nurse, I want you to be in charge of the oxygen saturation monitoring.
Yeah.
And so I want anybody to feel that they can speak up. I'll share with Juan a story from, I won't put it, it's a good video you can watch about when this goes wrong. It's from the UK, it's from England. And a woman is going for a routine surgery. Her name's Elaine Bromley, and she eventually dies. She's just going for an ENT surgery, routine. and no one in the room, so the 3 anesthetists try and intubate her. They are unsuccessful. Her oxygen saturation's dropped. They keep trying to intubate her. And no one, the nurses are at the end of the bed with the crate kit, the trach kit. But no one felt okay to speak up. And the ENTs, the surgeons keep trying to intubate her. They keep trying. Her oxygen drops. No, they can't do it. The anesthetist can't intubate her. Eventually, they decide to wake her up, but she doesn't wake up because she suffers a hypoxic brain injury. And her husband, and she dies, unfortunately. Her husband, who I know, he's a pilot. And he's created his whole career around getting people to speak up in crises because of what happened to his wife. And I'll share with you the video. I'll send the video to Juan so you can watch it. But I want everybody to speak up if they see a problem. I would never want something like that to happen. So I task one person to say, you're in charge of watching the O2 saturation, but everybody should feel comfortable to say, hey, there's a problem. You got to stop, or you have to change your plan.
One last question. I'm sorry. I have to.
That's okay.
How do we teach that to our residents? Well,
two ways that I do. One, I model it myself. So I do it myself. I have a resident beside me. I say, listen, I'm going to tell our nurse, we're going to signpost this decision. Or I prompt them to say, listen, are there any circumstances you're going to stop to intubate? And they might say, yes, or no, I'm going to intubate. But, well, what if this oxygen drops? Oh, well, then I would stop. Okay, at what number? Okay, and then I bring them through that right before they're going to be intubating. So I prompt them. So on the job teaching, I teach them, talks like this, we talk about it. These are things that we are regularly talking about. And so it is something that I will model myself, and I will prompt people for more of the high stakes decisions, the decisions that are really important. And I don't signpost everything, but I try and pick the things that really matter.
Okay, but you do it in simulation, right? These soft skills that we need the residents to learn.
Both simulation and real life. Okay. Because our residents, they don't get enough time with just me. So if I have them in simulation, I don't teach all of them all the time, but we will teach it in simulation. But also every time I have every intubation, the actual real intubation, I tell them, we're going to signpost. And so that is, one of the ways. Yeah, I teach them on the job as well.
Thank you so much. Thank you.
Yeah, you're welcome. Great questions.
Doctor Daniel Pérez.
I'm okay to stick around for a few minutes if people have questions.
Do you listen me there?
Yeah, go ahead.
Okay, thank you, Dr. Andrew. This is so amazing topic. I like this topic a lot. I've been trying to get into this kind of stuff with all the residents because I think disabilities are not soft, are really, really hard. And I've been getting some trouble trying to teach to my residents. So I think all these tricks, all this experience you share with us, they are just amazing. The Luciana just asked to you, I think all the things I got in mind. So I just want to thank you for sharing your time and all these. I think they are high topics and tricks we can do in our service, in our practice, and with our students to get it better and better. Thank you so much.
Well, well, yeah, you're most welcome. The very kind words, and I'm glad that this is something that you found helpful. So yeah, that's great. Thank you. It's a pleasure and an honor to have an invitation to speak with you guys.
Hey, I don't see other hands, Dr. Andrew.
Yeah, no problem. If anybody has...
The Dr. Carlos Barros, Profe Barros.
Dr. Andrew, good morning.
Good morning.
Thank you. Thank you for your presentation. It's very nice. It's a great thing. I have a question. In your everyday, do you use cognitive autopsy? What do you think about this tooling in resident training and case analysis?
What is it?
Cognitive autopsy.
I don't know it. How do you...
Escribe
is
en
it
el
a...
chat.
Okay.
Yep. Can you put it in the chat?
Cognitive.
I think
Okay.
it's like when you got a hard case and you do like a debriefing, but most about the thinking about the process of why did that person take that decision on that moment. I think it's kind of what he's trying to say the Dr. Barr.
Yeah, okay. What's the maybe I just misunderstood. How do I maybe, yeah, put it... yes. So how do we use how do we use that in our practice, or how do we like reflect on that? Is that what you're asking?
Yes, with residents doing analysis of case.
Yes. Yeah. So there are some different frameworks to use, I guess, but most of the time we try and be active. The first thing I try and do is not focus on the outcome of the case if we're reflecting on the case. Because so many times, let's imagine a patient comes in with cardiac arrest. Okay, they're dead. We're doing our best. We do CPR. Maybe we intubate them. We give epinephrine. Maybe they need a shock, defibrillation. But many times it's just not, we can't save them. That doesn't mean we did anything wrong. In fact, we could have run the best resuscitation possible. And so I try and break down what happened. What were the things that we did? What were the tasks that we did? Break down, because the big cases are complex. So I try and break them down into smaller pieces and talk about each one, each part, and ask people, what information did we have in the moment about that particular thing? Why did we decide to give, epinephrine? Why did we decide to intubate the patient? What were the pieces of the information, or what information did we have at that time? So I try and think about what we had in the moment that allowed us to make that decision. And were there opportunities to get more information quite quickly or not? And sometimes you don't know why the patient arrested until they do an autopsy, and then you find out they had, an aortic dissection or something. And so, but that wouldn't be knowable. You would not be able to know that in the moment. Is there any way we could have known that? So I spend much more time on the process, and I break it down into small chunks than I do worrying about the outcome. The other thing I do, for example, when possible, I don't know, do you guys use video laryngoscopy when you're intubating? Or do you use direct video?
Yes,
we use
we
video.
do.
Okay. So, for example, when a trainee is intubating a patient, I'll stand beside them, you know, if they're more junior. If they're a senior trainee, then I might be farther away and not, you know, watching them so closely. But if we think about a trainee intubating a patient, let's say they successfully intubate the patient. Just because they successfully did it doesn't mean they did a great job. They ultimately got the outcome that they needed. But I will do things like I will press the video record on the video laryngoscopy. We use GlideScope or sometimes, what's the other one we use? Yeah, GlideScope most commonly. It has a recording button. And so then I can go back with the resident afterwards and review their process, their technique, and it's objective. It's not me coming up with what we see. We both look at the screen together. And so then we can reflect better about the specific decision, about how they moved the tube. So if you can use things that are objective, like video, then you can have a better conversation. Then people don't feel so much that you're attacking them. You're both looking at the screen together and you're like, oh yeah, you should move the tube over to the right or to the left, or you didn't create a good view of the cords, and here's how you can do it next time. And so it's very much less about the outcome. We know the patient got intubated, but how can we do it better so that the next time when it's even more difficult, we can achieve what we need? So I try and very much break things down and focus on the process.
Okay, I understand. Thank you, Dr. Andrew.
Okay, we don't have other hands. Thank you, Dr. Andrew, again. It's an honor to have you here. So we can end the talk.
Yeah, thank you very much, Juan, for the invitation. I'll follow up with you by email, and it's a pleasure. Thank you for all of you folks joining, and I hope to come to Colombia one day and you know, maybe share ideas and talk emergency medicine in person.
If you don't matter, can you put your email? So.
Oh yeah, anybody can email me.
Okay.
Oh, my chat's not working. Hold on. Let's see. My chat isn't working. So
I will put it on the chat.
If you authorize, then Juan will give it to us. It's okay.
Oh yeah.
Juan,
send out the email. I'll send you you have my email, so just send it out to everybody.
Okay.
Thank you so much.
I will do that.
Okay, great. Well, thank you very much. I hope you all have a wonderful day and a wonderful weekend, and you save many lives.
Thank you, Dr. Andrew. Bye-bye.
Bye.